Hello, everybody. Today, my group and I will be preventing sexually transmitted infections among high school students in Hamilton County, Tennessee. This presentation is for our Design and Analysis of Public Health Interventions course taught by Dr. Lori DeWald. To begin, I want to introduce you all to the members of the Blue Group. To begin, we have Ariel Favela. He is presenting the methods used slide and the pros and cons slide. Next, we have Landry Parker. She is presenting the construct diagram, the primary construct, and the secondary construct slide. And lastly, we have Shinara Ume, who presents the title and introduction slide, history of the social cognitive theory slide, critical evaluation, and alternative theory slide as well. To begin, I want to describe the history of the social cognitive theory. The social cognitive theory is the theory that we chose for our intervention method. In the 1960s, the social learning theory was created by Albert Bandura. In 1986, the social learning theory transformed to the well-known social cognitive theory. When firstly created, it had 5 constructs. These 5 constructs were reciprocal determinism, behavioral capability, observational learning, reinforcement, and learning. And once social learning theory transformed to social cognitive theory, the 6th construct was added, and that 6th construct is self-efficacy. Social cognitive theory is unique in that it considers the way in which people acquire and maintain a behavior. Social cognitive theory also takes into account the social environment in which a person performs a certain behavior. The main goal of social cognitive theory is to explain how people regulate their behaviors through control and reinforcement to achieve goal-directed behavior that can be maintained over time.
The behavior theory we will be using for our intervention is the social cognitive theory. The social cognitive theory asserts that learning occurs in a social context with a dynamic and reciprocal interaction of the person, their environment, and their behavior. The social cognitive theory is within the interpersonal level of the social ecological model and recognizes that although intrapersonal factors are important, it is not a sufficient foundation for behavior change because personal factors, environmental factors, and human behavior are all interdependent and exert influence upon each other. The rising rates of sexually transmitted infections can be attributed to the interactions between the personal, behavioral, and environmental determinants surrounding unsafe sex practices. The personal determinants of high school students engaging in unsafe sex practices may include relaxed attitudes towards preventative measures and the belief that they are not at high risk for contracting an STI. The environmental determinants include the lack of education they receive from their high school sex ed courses due to Hamilton County requiring public institutions to teach strictly abstinence-based curriculum rather than medically accurate sexual education courses. Finally, the behavioral determinants include students engaging in unsafe sex practices such as not using condoms, having multiple sex partners at a time, and not getting tested for STIs regularly. The primary construct from the social cognitive theory we will be using is behavioral capability. Behavioral capability is defined as an individual's actual ability to perform a behavior through essential knowledge and skills. This construct is particularly important to the target audience due to the lack of knowledge on how to practice safe sex due to Hamilton County's sex education curriculum. The abstinence-based curriculum students receive requires educators to only teach STI prevention through abstinence. Because of this, teachers cannot tell students other measures to prevent STIs, such as wearing condoms, because this is seen as promoting sexual activity. Our intervention will use the construct of behavioral capability to fill the gap in the students' knowledge on how they can prevent contracting an STI if they choose to partake in sexual activity by teaching and promoting preventative measures. The secondary construct from the social cognitive theory we will be using is self-efficacy. Self-efficacy is defined as the level in which an individual is confident in his or her ability to successfully perform a behavior. If students doubt their ability and don't believe that they are capable of making changes, this can limit their desire to put forth enough effort to achieve behavior change. Our intervention will be giving them a lot more education than they have previously received from their high school sex education courses. So it is important that we incorporate methods of increasing self-efficacy levels to keep the students' confidence high and help them believe that they have the ability to make the necessary changes. Our intervention will include having students make personal, attainable, short-term goals that are specific to their lifestyle to ensure that they see the progress they are making and feel successful throughout the intervention.
To better understand the social cognitive theory and how it can be applied to a health program intervention, we will be looking at a couple of case studies that incorporated this theory and see what results they achieved using it. The first case study is an obesity intervention that was done amongst adolescents ages 13 to 16 living in industrialized countries, specifically United States, Australia, and Canada. The main goal in all the studies that were done in this article was to promote physical activity and healthy diet in order to reduce BMI. All studies ranged from 12 weeks to 1 year, while all of them did include educational methods in which they would apply the constructs of the social cognitive theory, whether this was through an instructor, a mentor, or different courses that were applied for the community. The main constructs that were incorporated in this from the social cognitive theory were self-efficacy, outcome and expectations, and behavioral intentions. While some of the studies did show that there was an improvement in BMI using the social cognitive theory, the grand majority did not show any improvement in reducing the BMI of individuals using the social cognitive theory. So evidence was weak, specifically to this intervention in reducing obesity. The next case study was done in Iran amongst adults with the main goal of rational antibiotic use using the social cognitive theory. This program lasted 13 months and also incorporated educational methods to apply the social cognitive theory, which was more on providing knowledge and providing education on the importance of complying to proper antibiotic use for proper health. The main constructs that were used in this case study were knowledge, outcome and expectations, and self-efficacy. For this specific case study, we did see that providing the knowledge and resource to these participants did actually decrease the inappropriate use of antibiotics. After analyzing those case studies and looking at other literature, we are able to see what some of the pros and cons are of using the social cognitive theory in a health program intervention. For a few of the pros, we can see that the social cognitive theory is great in increasing general awareness and altering beliefs on a specific target health behavior. Also, we are able to see that behavioral interventions are successful that revolve around the promotion of knowledge, thus leading into greater self-efficacy for the participants. And finally, we can see that it is also a great tool in understanding how environmental factors affect behavior and what is the importance in taking those into consideration when working with a specific target population. A few of the cons, however, that we can see is that there can be bias from self-reports and surveys done because unfortunately for the social cognitive theory, it's not something that can be very measurable by the most part, but is usually done in the form of reports or surveys that can cause bias. Another thing that we can see specifically with the first case study that was based around obesity is that sometimes the social cognitive theory requires longer interventions to achieve the specific health promotion, especially if that health promotion is revolving around providing knowledge to increase self-efficacy. Different people learn at different paces and grasp concepts at different speeds, so different promotions, health promotions might take a little bit longer. And finally, one thing that we can see is that you may require a combined model in your health program, which means that you may need to use a second theory to make your health program well-rounded in the parts that the social cognitive theory is lacking.
Next, we would like to discuss critical evaluation and gaps in the social cognitive theory. Although social cognitive theory is a well-known health behavior theory and an effective method for certain intervention strategies, there are some limitations that can arise. To begin, Social cognitive theory is known to lack structure. This theory is difficult to implement all structures at once, and when implementing this theory, it works best when focusing on only one or two constructs, and this could be limiting. Social cognitive theory also assumes that changes in a person's environment will automatically change a person's behavior, and that is not necessarily true. Social cognitive theory also does not take into account how biological differences in hormones play into a person's behavior. Social cognitive theory also does not consider how emotions can affect a person's behavior. This is extremely important to consider due to how our target audience is teenagers. And teenagers, as we all know, go through mood swings during puberty, and this can affect their behavior. Lastly, social cognitive theory does not account for genetic differences that could lead to differences in a person's behavior. Next, we want to discuss alternative ways to achieve behavior change. To begin, we want to start with the health belief model. This model assumes that an individual's readiness to change is based on their assessment of the threat of a health problem and the likelihood of being able to reduce the threat through personal actions. Using this model, you can focus on the student's perceived susceptibility of getting an STI, perceived severity of getting that STI as well, perceived benefits and perceived barriers that a student may face. However, this model relies heavily on students considering different options before deciding on a behavior change, and this could be difficult when working with teenagers. Next, we want to describe the theory of planned behavior. This theory assumes that behavior can be predicted by a person's intentions to perform a behavior based on their attitude toward the behavior, subjective norms toward the behavior, and perception of control over their own behavior. Theory of planned behavior recognizes that students' attitudes are affected by personal beliefs concerning the possible consequences for an action or behavior, while also considering the importance of the eventual outcome and address the development of these attitudes and beliefs. Lastly, we want to discuss the trans-theoretical or stages of change model. And this model assumes that behavior change involves movement through stages of change as opposed to an isolated incident. The trans-theoretical model of change suggests that cognitive and emotional processes initiate movement from one stage to the next, primarily from pre-contemplation stage to contemplation stage. A focus on knowledge and attitudes at this point could be an effective method for high school students. Here is the end of our presentation. This is our reference slide. Thank you so much for taking the time to listen to our presentation. If you have any questions, please leave them in our comments. And thank you so much for your time. Have a great day.